Good afternoon and welcome to Samaritans Purse International Health Forum. We're delighted for you to join us today. Hopefully you didn't stay up as late as I did, staying tuned in to the presidential elections. Amazing outcome, but that is a topic for another time. Staying focused on the webinar today, I'd like to remind you before we get started to just utilize your chat box during the presentation. And we will also, at the end, dedicate time to Q&A. We would like to entertain your questions to this excellent presentation today. Before we get started, I'd like to open up in a word of prayer. Beth?
Pray with me. Father God, we thank you for this opportunity to come and learn and grow today. We thank you for Dr. Sawyer and his work here in the United States and also abroad, and the presentation that he's prepared for us. Lord, I pray that you would use him to speak and teach us and help us to grow and learn and to utilize these practices when we go about our work and our service overseas. In your name we pray. Amen.
Thank you, Beth. So today I'm delighted to introduce Dr. Alan Sawyer. Dr. Alan Sawyer has been an obstetrician and gynecologist practicing for over 25 years. He has served with Samaritan's Purse World Medical Mission in multiple countries, including Papua New Guinea, Kenya, Togo, and Cameroon. Dr. Sawyer is a two-time graduate of Stanford University, and he is also a graduate of Oral Roberts University School of Medicine. He and his wife, Teresa, and their 4 children currently reside in Arizona. So today, I'm excited to have Dr. Alan Sawyer present Postpartum Hemorrhage. And without further ado, I'll turn it over to Dr. Sawyer.
Oh, good. Well, thank you for joining us today. I'm going to be speaking today on postpartum hemorrhage. If we can go ahead and go to the next slide. This is an enormous topic, and it was actually hard to kind of stay focused and avoid going down a bunch of rabbit trails, but I'm really going to try to focus today on how to reduce the morbidity and mortality of postpartum hemorrhage in developing countries, especially realizing the limitations that we have practicing in resource-limited settings. And then also, just from a practical standpoint, talking about how to create a postpartum hemorrhage cart and how do you manage massive blood needs in developing countries. We'll go to the next slide. As Lance just said, you can put in a chat message during the presentation as you think of questions. Just please enter those into your chat, and then at the end, Lance or the moderator will ask me the questions and I'll be able to respond to those. Go to the next slide. I'd like to start with a case presentation. This is a case of a 19-year-old that I delivered in 2015, the summer of 2015. She presented in active labor and had a completely uncomplicated vaginal delivery. The placenta delivered and everything was fine. Went over to the next room to deliver another baby, and I was called back in by the nurse because this patient was hemorrhaging. Go to the next picture. Came in and the nurse reported that the patient had lost about 1,000 cc's of blood. I gave Methergin intramuscularly, and we started a second IV line, ordered blood. Go to the next picture. We did bimanual massage and did rectal administration of 1,000 micrograms of Misoprostol, called in extra nurses and the anesthesiologist to come in. The uterus was still very boggy, and checked to see that the placenta was completely out. We'll go to the next picture. At this point, I opted to place a Bacri balloon under ultrasound guidance. I found that ultrasound guidance helps tremendously with placement of a tamponade device. And then there was, we also started a massive transfusion protocol, which at our facility means just making one telephone call to the head nurse in labor delivery who notifies the blood bank that we are going to need a lot of blood in labor and delivery. Go to the next picture. We transferred the patient to a recovery room just for better monitoring. It was a room that was very close by. She was tachycardic and hypotensive. The Bacri balloon bag, which is like a Foley bag, was completely full of blood. It had about 1,500 cc's of blood in it. And the patient's boyfriend and mother were sitting there in the room watching everything that was going on. Next picture. Our worst nightmare is that the patient then went into asystole. We started CPR, called a code to labor and delivery. We were infusing crystalloids. O-negative blood was transfusing as part of our massive transfusion protocol. And we started chest compressions, and very gratefully we were able to get her heartbeat back in about 30 seconds after chest compressions. Go to the next picture. She was bleeding from all of her IV sites. As part of our massive transfusion protocol, we were drawing series of labs, and I always have them draw an extra red top tube. I keep that red top tube in my pocket, and I can look at it to see whether there's any evidence of blood clot, and it was not clotting. So clinically, between looking at her IV sites and looking at where she was bleeding from and looking at my little red top tube, with non-clotting blood in there, I knew that she had a consumptive coagulopathy. We transferred her immediately to the operating room. We gave her endotracheal anesthesia. Go ahead and switch to the next picture. We took her to the operating room. I did a supracervical hysterectomy using a ligature device, which is a wonderful device to clamp and coagulate at the same time. Actually had very minimal blood loss in the operating room. I did leave a Jackson Pratt drain in at the end, and we gave her packed red blood cells and platelets and fresh frozen plasma and calcium, which is all part of our massive transfusion protocol. Next picture. We transferred her to the intensive care unit, intubated, checked out to the critical care team. She was stabilizing. She had minimal blood in her Jackson Pratt tube, and at this point it appeared that the consumptive coagulopathy had been reversed. 3 hours later, next slide, or next picture, we got a phone call from the ICU, or I got a phone call from the ICU saying that her Jackson Pratt drain was filling up as fast as the nurse could change it. And this is one of those little tiny 100 cc bulbs, so I had her change out that to a 500 cc bulb. I called the pharmacy on my cell phone as I was walking back over to the ICU and made a special request to the pharmacy. And then by the time I got to the ICU, just 5 minutes later, the Jackson Pratt drain was completely full of blood. The 500 cc bulb was completely full of blood. Next picture. There were 3 pharmacists that came up to the bedside to reconstitute Nova 7, which is a recombinant factor 7. And the RN gave that medication. That was $12,000 worth of medication given in one IV push. But there was a rapid reversal of the coagulopathy, and the patient survived and did well. And it's been extremely grateful for her care. I'm even being 19 years old with a hysterectomy. We'll go to the next slide. So postpartum hemorrhage is just by definition is postpartum hemorrhage that happens within the first 24 hours after delivery. Outside the scope of this lecture is what happens with a delayed postpartum hemorrhage, which is any bleeding or hemorrhage that happens after 24 hours to the first 12 weeks after delivery, sometimes called a late or a delayed postpartum hemorrhage. Next slide. This picture was taken by me at Tenwick Hospital. I was in a meeting upstairs, having morning conference, I think, and I got called out. Patient had just been diagnosed with polyhydramnios in the 3rd trimester and a baby with anencephaly. And I got called downstairs to the labor room, and this is what I saw. The midwife immediately recognized postpartum hemorrhage and called for help. And just illustrating my point that early recognition is critical, and getting help is critical with postpartum hemorrhages. Go to the next slide. postpartum hemorrhage is not a problem just of the underdeveloped world, but it's a problem in a developed world as well. Postpartum hemorrhage occurs in 1 to 5% of deliveries, so it's something that obstetricians are not used to dealing with. The absolute risk of death is about 1 in 100,000 deliveries in a developed country, but in underdeveloped countries, it's 1 in 1,000. So it's an enormous problem. So we need to anticipate this is going to be a problem. And I think the biggest thing as an obstetrician is looking at or just knowing which patients are at risk. A patient that delivers a 10-pound baby, patient attempting a vaginal birth after a previous cesarean section. One that always strikes fear into my heart is a patient with a past history of postpartum hemorrhage, because the recurrence risk is about 10%. Patients with multiples, having twins or more, patients with an infection with chorioamnionitis, patients that are going to refuse blood products. You just don't have any room to wiggle in this patient population. So you really need to be prepared and be extremely proactive if you have like a Jehovah's Witness patient that won't accept blood products. Magnesium sulfate, platelet counts under 100,000. A history of a previous endometrial ablation is a disaster in the delivery room in terms of postpartum hemorrhage, and then abnormal placentation. In terms of causes of primary postpartum hemorrhage, by far and away the most common is uterine atony, and we just discussed the risk factors, but also obstetrical trauma. If a patient tore the cervix, or you have a macrosomic baby and have vaginal sidewall lacerations, and also congenital coagulation defects. So these 3 categories have to be going through the clinician's mind as you consider what's going on. Again, recognizing that most of the time it's going to be uterine atony, but it's not always going to be uterine atony. And sometimes it can be multiple things, like what I just discussed in my case presentation, where it was uterine atony, but then we had a coagulation defect on top of that with a consumptive coagulopathy. So I think one of the key things that every hospital, every labor and delivery unit can do, whether you're in a developed world or underdeveloped world, is have a postpartum hemorrhage cart. The picture on the left is the postpartum hemorrhage cart at Mabigo Baptist Hospital in Cameroon in West Africa, and the tackle box on the right is the postpartum hemorrhage cart, so to speak, from my own labor and delivery unit here in Phoenix, Arizona. The reason our tackle box is so small is that we have everything that we need in almost every delivery room. So we don't pack that one like we do the one in Cameroon. But the one in Cameroon is, let's go back to the previous slide. The one in Cameroon is located just outside the operating room. And all patients with a postpartum hemorrhage in Cameroon at Mabigo Baptist Hospital are brought to the operating room. So labor delivery's a short distance away from the operating room. It's really not set up to deal with catastrophic blood loss. And so those patients are brought up to the operating room. At our hospital in Arizona, the patients are managed right in labor delivery, but if we have a postpartum hemorrhage that happens out on the postpartum unit, we bring those patients back immediately to labor and delivery, just because there's additional monitoring that you just don't have out on the floor. So what do we put in our carts? All the critical things that we need. We have Misoprostol tablets, we have Bacteria balloons, IV tubing, laboratory supplies, the right tubes to be able to draw the blood, curettes. These are all essential items to have inside of your cart. Also, another thing to have is some kind of a flow sheet that's available for everybody to refer back to. And this sheet that's on this page, I know it's busy, but I'm going to break it down. This is from Up to Date. And I really like this chart because it divides, on the left column, it has everything that the nurses need. And on the right column, it has, or left column is the nurse's responsibility, and the right column is the physician's responsibility. And so it's a wonderful resource. I think something like this needs to be printed out and put inside of the postpartum hemorrhage cart. Go to the next slide. This is the medicines that are in the Mabingo Baptist Hospital cart, and they have this little sheet of paper for after the cart has been used to make sure that the cart gets restocked. And you see all the medications here. I did have to kind of laugh because there's Cytotec. There's actually 3 containers of Cytotec in here, so that's kind of the most important thing. I did kind of laugh and take a picture of the methylene blue because you can't hardly find methylene blue anywhere in the world anymore. And then the expiration date on this was from September of 2013. But methylene blue, if you want to try to see where your ureters are, for some reason. Go to the next slide. So just to review the medications and what you can do with these and the order that they're used. Pitocin obviously is used as a mainline drug in all cases, actually for every delivery, I think. You just want to avoid undiluted rapid infusion of Pitocin. You can use it intramuscularly or intravenously. It does have an antidiuretic effect, so you have to be careful of fluid overload if people are getting large doses of this. Misoprostol is such a ubiquitous medication in terms of obstetrics. I actually keep a bottle of misoprostol in my pocket of my lab coat whenever I'm working in a developing country. For several reasons. One is because we use it for everything in terms of induction of labor and postpartum hemorrhage. But I also ran into a problem in one hospital I was at where the misoprostol just wasn't effective that was being purchased at the hospital. And I think it was actually a black market form of the misoprostol that it wasn't misoprostol at all. It just was like a sugar pill and had no effect. So I actually bring my own misoprostol when I go on mission trips and keep it in my pocket. It's a critical drug though. It takes 6 to 12 minutes to work, so you have to keep making sure you're giving IV fluids and doing uterine massage while you're waiting for it to work. But you can give 800 to 1,000 micrograms of this rectally. It's absorbed very well. It's extremely versatile. You can do oral, sublingual, vaginal or rectal administration of this medication, which makes it very versatile. The only contraindication is an allergy to it. So it's just a life-saving medication for an obstetrician. Hemabate is available here in the United States. It's not going to be something that you're going to find very often in a resource-limited country. It has to be refrigerated, and it can be given intramuscularly. It actually can also be administered right into the uterus. So if you're doing a C-section and you have a postpartum hemorrhage, you can administer the Hemabate right into the uterus. You have to be careful in patients that have asthma because you can exacerbate an asthma attack. And you also can't ever give this IV. It also does tend to cause profuse diarrhea. So we tend to pre-medicate these people to try to prevent post-administration diarrhea. Methergin is also commonly used and readily available. It comes in these nice little ampules of 0.2 milligrams, and you give this intramuscularly. You're not supposed to give it IV. It'll cause hypertensive crisis if you do that. And you just and also you have to be careful in preeclamptic patients that are hypertensive that you don't give this, or a patient with chronic hypertension, that you don't give this to a patient with hypertension. Then I mentioned this in my case presentation. This obviously won't be available in a developing country, but if you are in the United States with a severe postpartum hemorrhage, having Nova 7 or recombinant factor 7A available is incredibly effective for reversing a consumptive coagulopathy associated with a massive postpartum hemorrhage. It's extremely expensive, as I mentioned. We used 3 ampules of this for my patient, and that was a cost of $12,000, but it can be life-saving. The downside of this is that it can also cause thrombosis in other parts of the body as well. You also need to be certain that your platelet count's over 50,000 for it to work, and that you don't have that you don't have acidosis, and also that your patient's warm. So that's important. As I was preparing for this, I read a lot about estimating blood loss and trying to get accurate blood loss estimates in your patients, and I just don't see that this is clinically very effective in terms of people taking time out to measure blood loss. You kind of have to know it when you see it. But I thought that this was a helpful graphic presentation of when things are going wrong. A peri pad with a little bit of blood on it's 100 cc's. If you have a full kidney basin full of blood, that's about 500 cc's. If you have a patient laying in a pool of blood with half the mattress saturated, then you're looking at about 1,000 cc blood loss. But a lot of this just is intuitive by being around it all the time. But if you're not taking care of these kinds of patients all the time and you're not used to looking at blood loss, this kind of graphic is helpful. But also on the next slide, looking at the patient's clinical presentation is helpful. If you have a patient that has a normal blood pressure and she's having some palpitations, lightheadedness, mild increased in her heart rate, then you're probably looking at somewhere between 500 and 1,000 cc's of blood loss. If you start to have weakness and sweating and tachycardia, then you're looking at 1,000 to 1,500 cc's of blood loss. You start to see a significant drop in systolic blood pressure. Patient becomes restless, becomes oliguric and tachycardic. Then you're dealing with a much larger volume of blood loss, 1,500 to 2,000, and then lethargy, air hunger, tachycardia, or as my patient had, asystole. Then you're looking at blood loss of 200 or 2,000 to 3,000 cc's, and also with profound hypotension, with systolic blood pressures down to the 50s to 70s. So next slide. I mentioned this briefly earlier, but this up-to-date slide that shows the nurse's responsibility on the left, and then the physician's responsibility on the right. And then I want to go through this slide breaking down into sections. So we'll go on to the next slide. From a nurse's responsibility for a stage 1 or 0 to 1 postpartum hemorrhage, the nurses should recognize that this is going on and start Pitocin and oxygen and crystalloids. They should be getting help, and also putting in a Foley catheter is extremely helpful in emptying the bladder so that the uterus can compress down. With a stage 0 to 1 postpartum hemorrhage, physicians should recognize the problem, begin massaging the uterus, and administering pharmacologic treatment, including Pitocin and Misoprostol.
Dr. Sawyer, so I'm going to take a moment just to entertain a question from the audience, if I could.
Sure.
This is a gentleman I believe you know, Dr. Mike Edom. His question is, any experience with tranexamic acid? We have stopped using Novo 7 because of the cost and the incidence of thrombosis. Tranexamic acid costs about $1 per dose and has been found to be very effective for consumptive coagulopathy.
I haven't seen that, but that's a great point. I'll have to look at that. So thank you for that, Mike. So looking at now a stage 2 hemorrhage, now your blood loss is 1,000 to 1,500 mLs. The nurse's responsibility is to assess the vital signs and respond. Make sure you have your second IV access communicate that we have a massive transfusion situation with however your facility does that. Notifying the operating room and anesthesia that we're in a acute postpartum hemorrhage situation, and keep the patient warm. From a physician standpoint on the right, it's deciding which medicines you're going to use, ordering the correct laboratory tests. I would add, put a red top tube in your pocket so you can just look at it to see whether you're getting any clotting. Staying 4 units of blood ahead on packed red blood cells, considering an O negative transfusion. And then also, you need to consider your etiologies here. So is this a uterine atony? Is there a laceration? Are there retained products of conception? Is there a risk of coagulopathy, whether it's congenital or consumptive? And just by even looking back at the red top tube in your pocket. But you need to be thinking about the three things: uterine atony, lacerations, retained products of conception, and then coagulopathy going on. And then next slide. So in terms of massive transfusion protocols, I just put this slide in there because here in the developed world, we have access to all these different blood components. We can give packed red blood cells and fresh frozen plasma and platelets. But in the developing world, you have this wonderful thing called whole blood. And it's actually an advantage. I called my own hospital's blood bank last week when I was preparing for this, and I said, can I get some whole blood sent up to labor and delivery? And they just laughed at me. They said, no, you can't have whole blood. We don't do that. But I was just testing them. So, but whole blood is not depleted with these wonderful clotting factors and platelets. And it's a wonderful thing about being in a developing country. You can just give whole blood, which is usually what they have. Go to the next slide. So then looking at a stage 3 postpartum hemorrhage from a nursing standpoint, now you're over 1,500 mLs of blood loss. The nurse's responsibility is to communicate the vitals to the team and watch and communicate hemodynamic instability to the rest of the team. And then for the physicians, it's activating the massive transfusion protocol, having anesthesia place central lines, placing some kind of a uterine artery or uterine tamponade balloon like a Bacri balloon. If it's a cesarean section, then considering using a Bacri balloon that you can put in right through a hysterotomy incision, or using a Lynch suture that I'll talk about in a little bit. And then is interventional radiology a possibility in terms of placing or helping to control the hemorrhage using interventional radiology? Of course, that's not going to be available in a resource-limited setting, or do you need to proceed with a hysterectomy and then transferring to an intensive care unit setting after surgery? Go to the next slide. So the Bacri balloons are wonderful to have. I usually try to take some of them with me overseas. I've written to when I go overseas, I've written to this company, Cook, and asked for donations in the past, and they've been just wonderful in terms of donating a few of these for me to take because they cost $250 each. And then I also download this demonstration video, and the link is on here. You can just look it up on YouTube. But and I download this video onto thumb drives, and I take it and give it to some of the doctors in these other hospitals so that if they're not familiar with how to place a Bacri balloon, that they can look at this video right on a thumb drive, since it's so hard to sometimes download video in developing countries. And then I also just recommend doing ultrasound guidance as well when this Bacri balloon is placed. And this is a wonderful way to make your own homemade Bacri balloon. This is from Johns Hopkins website, which is at the bottom of this, and I also repeat it on my final slide so that people can have this link. But this is basically a homemade Bacri balloon. You need your clamps and a retractor. You need a Foley catheter, and you put a condom over the end of the Foley catheter. You take some suture and tie the end of the condom around the Foley catheter, and then you infuse 500 cc's of saline into the Foley catheters, just like you would with a Bacri balloon, and then you connect the end of the Foley to a collection bag, and you can monitor. Actually, not in this situation. There's no collection system, but and then you give antibiotics, and then you slowly take this down over the next 12 to 24 hours. But this is a very inexpensive Bacri balloon that can be utilized on almost any resource-limited setting and save lives this way. This next slide is a B. Lynch suture. This is very helpful. It's very inexpensive. Can be done at the time of a C-section, where you have unresolved uterine atony and postpartum hemorrhage. And the little paragraph there does a nice job of explaining exactly how you do this. But you take a chromic suture, and you go in at point A and come in at point B on either side of the right side of the hysterotomy incision. Go up over the uterus, down around the backside, come in to the uterus at point C, come out at point D. So your suture is now coming out on the backside of the uterus. Come back over the top, and then the suture goes in at E and comes out at F, and then you tighten the whole thing securely and suture it. So this is very helpful. This slide came off of UpToDate, and they have a wonderful description on UpToDate. And actually, I don't own any interest in UpToDate, but UpToDate is a great resource to have. I carry it on my tablet. I download a complete version of it on my tablet and have it with me when I go and work overseas, because I just find myself referring back to that all the time. And then also, I get over 100 units of CME per year just by reading different things on UpToDate. And in a resource-limited setting, it's great to just have it with you all the time. You can have the whole thing on your tablet, and you don't have to be hooked up to Wi-Fi at all. So what are the take-home points? The take-home points really are to have a postpartum hemorrhage cart available at any facility that you're working at. Consider the special needs of that facility, and have it located in the place where you're going to manage these patients. If that's going to be the operating room, fine. If that's going to be labor and delivery, fine. But everybody needs to know where that cart is all the time, and somebody really needs to be checking that periodically to make sure that your medicines aren't expired and that people haven't pilfered the stuff out of it, and everything like that. You need to discuss with your team where's the treatment location going to be, so that the nursing staff knows that if you have a postpartum hemorrhage at Mabingo Baptist Hospital in Cameroon, that patient's going to be transferred up immediately to the operating room, because that's where everybody is and that's where all the supplies are. Having some kind of a massive transfusion protocol with a chain of command, is that calling your head nurse of the operating room, the head nurse of labor and delivery? Is that calling the blood bank? And what's the chain of command on that? But mostly I think that it's important that the blood bank know that you're going to need a bunch of blood fast. And then uterine artery uterine balloon tamponade, knowing where your Bacri balloons are, having all the things that you need to do a condom and a Foley tamponade available and sterile, so that you can just grab your stuff from your postpartum hemorrhage cart and put that in without trying to run around and trying to create this thing in the heat of the moment. And then the condom tamponade balloon is that whole education video and resources are at this website, reprolineplus.org, put together by Johns Hopkins University, and that's easily accessible on the internet. I think that's the end of my presentation. So let's go back to that previous slide and just leave that slide up, and then I'll open it up to any questions that you might have.
Dr. Sawyer, thank you so much. That was an excellent presentation, especially I think for non-obstetricians in the audience like myself. That was, you presented with great clarity, and I appreciate your points. Maria Gallo, she does make a comment on tranexamic acid there. She states that at her hospital in the OR that they do utilize tranexamic acid and have had nice results, usually given at 650 milligrams IV. And that's after attempts at ligation and utilization of Cytotec if those measures do not work. And then Dr. Cheatham follows up that we give 1 gram IV and a 2nd gram within 3 hours. It is a part of our massive transfusion hemorrhage protocol. And I agree with you, Dr. Cheatham. I was going to say the same. Alan, we love your homemade Bacri balloon. You really have to have innovation in the developing world, and that is a great example. So thanks for sharing that. Dr. Sawyer, any other comments about postpartum hemorrhage with regard to utilization of like tranexamic acid or whole blood products?
Just knowing where I've been in developing countries and seeing how sparse the blood can be on the shelves, really encouraging the patients to bring in donors, that should just be a routine part of every surgery, every delivery, that patients need to come in and bring their donors with them, because most of those patients aren't going to need blood. But you're always going to have this stockpile of blood. So thinking back at the different places that I've been, patients just being told, look, if you want to have a surgery here, or if you want to deliver your baby here, you need to bring 1 or 2 donors with you so that there's a constant stockpile of blood.
That's a great point. Yep. It's nice. As you said, it's, here in the States and the domestic settings, we can't access whole blood, but that is, available to at least to a moderate extent in the developing country. So, and it is, it has, platelets and factors, blood factors. So that's something that certainly can be utilized. Also, Maria Gallo just comments about Dr. Cheatham. Perhaps his dose is a bit more up to date, and that she doesn't usually repeat it. I'm not familiar with the dosing on that. I'd have to look up the dosing on tranexamic acid. Just to add, we do in our disaster response formulary, we do have that available. And then Dr. Sawyer, Marvin Hage states that the importance he just emphasizes the importance of good lighting for evaluation and management of laceration.
I actually bring a headlight with me that I donate to the hospitals when I leave. And I think it was Jim Moore from Samaritans First that told me about or actually it may have been Bruce Steffes from PAX. I think it's actually intended for bicycle riding, but it's a $75 LED headlight, and the batteries are rechargeable. They just go in your pocket. But Bruce was saying that that's just as good as some of these $1,500 headlights that we take overseas. But yeah, lighting is absolutely critical. I always bring my own and leave it as a gift when I leave. But absolutely, you need good lighting.
Again, I want to thank you so much for that presentation. I think that's very informative. Again, to all of us that respond in developing world settings and our disaster response team. Pregnancy continues even in disasters and delivery. So this is very informative for us. Dr. Sawyer, thank you. Do you have any closing comments before we conclude?
No, I just appreciate the opportunity to finally give this presentation, and thank you for asking me.
Well, again, it was excellent, and we do appreciate your presentation today and your sacrifice to Samaritan's Purse and World Medical Mission. You've done outstanding work, and we really do appreciate what you've done.
Thank you, Lance.
Okay. Well, thank you all so much for joining us today here at the forum. God bless, and we'll see you next month.